So today we will start about impactions, okay, and the management of wisdom tooth. So first of all, what are the various theories of evolution of this? So evolution made wisdom tooth a vestigial organ. So previously it was used for chewing, okay, but with evolution now it has become a vestigial organ because first of all, we shifted from hard porous food to soft processed food. Okay. And then there is over the period of time, there was gradual decrease in arch and the jaw size, but the size of the teeth was same. Okay. So there was no proper space to erupt in the mouth. Okay. So over a period of time, it becomes a vestigial organ. So the management of third molar is a very commonly practice. It is It is known as impacted tooth also. So wisdom tooth surgery is one of the most commonly performed but poorly understood procedure in the dental office. Can you hear me?
Yes.
Okay. So dental surgeon should know about the consequences of third molar management, right? According to Berger, the following are the local causes for impactions: the irregularity in the position and pressure of adjacent tooth, the density of the overline and surrounding bone, chronic inflammation with resultant increase in the density of overlying mucous membrane, lack of space due to underdeveloped jaws, unduly long retention of primary teeth, premature loss of primary teeth, disease such as infection or abscess, inflammatory changes in the bone due to axanthomatous disease in children. So these are the common local causes. The systemic causes are prenatal causes, hereditary, postnatal causes such as rickets, anemia, congenital syphilis, tuberculosis, endocrine dysfunctions, malnutrition. And some rare conditions are like cleidocranial dysostosis, oxycephaly, progeria, achondroplasia, and cleft palate. Achondroplasia is a type of syndrome. Okay. Now, what is the frequency of impaction? According to the formation from West German Federal Dental Association, the percentages are wisdom teeth 78%, canine 13.9%, premolar 4.6%, supernumeraries 3.1%, and others 0.3%. Correct? So third molar is the most common for impaction. Okay. The day before yesterday, we discussed about premolar extractions in ortho cases. Okay, so I discussed with Dr. Archana that why should not we engage the first premolar, make it mobilize, and then take it out for extraction. So she said that there will be an anchorage loss.
I understand.
Yeah, there will be an anchorage loss. So it's better not to engage it this our total procedure before because you will get an anchorage loss, definite anchorage loss there in your case. Okay.
I understand.
So I thought I should convey it to you also.
Yeah.
Then various summary of type of retention. Vertical retention, if the tooth is straight, like vertical retention. Then horizontal retention, it means sagittal, mesoangular like this or like this, distoangular, transverse, buccoangular or linguoangular. Or the tooth should be tooth may be like this or like this, mesoangular, distoangular. It is any of the horizontal retention of the or a horizontal impaction, you can say. Okay, then inclined retention, mesoangular, distoangular, buccoangular, linguoangular. Abrasion. Abrasion means sometimes the tooth is inverted, sometimes the tooth is in the ramus of the mandible, like this. So based on this, we have various classification and all are very important. Okay, the Winters classification, Pell-Gagry classification, case classification, AOMS classification, then ADA code of procedure or nomenclature, combined ADA and AMS classification, Patterson difficulty index, VARF assessment, and Winters war line. Okay, so your this dissertation will be on the war lines. Okay. The first is Winters classification. And now it is based on the position of long axis of the impacted mandibular third molars in the relation to the long axis of second molar. Okay. See, second molar is here. On this position, on the basis of this long axis, we classify third molar. Correct? So the classification is vertical, means like this, horizontal, correct, inverted, mesoangular, slightly tilted, distoangular to the opposite side, buccoangular to the buccal side, and linguoangular to the lingual side. All the angles in 360 degree. Okay, that is Winters classification. So in Winters classification, the lag was it only states about the angulations. It doesn't state about the level. Okay. So in Pell-Gagry classification, the levels are also added, but it was based on the space available for the eruption of mandibular third molar distal to second molar. Okay. This is second molar. Now the space available between this second molar and
Anterior border of the ramus.
yeah, and the border of mandible. Okay. So class 1, where it can be easily erupted. In class 2, it is the space is not available. Okay. Mild space is available so that the tooth can be partially erupted. In class 3, no space is available. So in class 1, we have a proper space. In class 2, partially erupted, and in class 3, no space. Then it is also based on the relative depth of the third molar in the bone in relation to the CE, means cemento-enamel junction of the second molar. Just a moment. So it is classified as A, B, and C. In position A, it is equivalent to the second molar on this level. Okay. On position B, it is between the upper limit and the CE junction, like this. And in position C, it is below the C junction. Correct? So again, we can say A, B, C. Correct? It is based on the position of it is based on the position of long axis of impacted third molar in relation with long axis of second molar. What we studied in Winter's classification. Okay, Winter's classification was part 3 of Bell and Gregory classification. Correct? So it is vertical, horizontal, inverted, mesoangular, distoangular, buccoangular, linguangular, okay, and inverted one. The next classification is case classification. See, this is very important chapter, and you might get a short note, or you might get a question regarding this. Okay. In case classification, it is based on angulation and positions. First is mesoangular, distoangular, vertical, and horizontal. Second is based on the state of eruption, fully erupted, partially erupted, or embedded. Correct? This is a very easy one. Then based on the number of roots, fuse root, 2 roots, multiple roots. Based on the root pattern, favorable roots or unfavorable roots. Favorable roots which are on the direction of path of extraction, okay, and unfavorable roots which are oppositely curved. Then the next one is Peterson difficulty index. Okay, so this difficulty index has to be calculated. First, classification, the spatial relationship. Okay, what is the spatial relationship? Mesoangular, horizontal, vertical, or distoangular. Okay, so for mesoangular it is 1, horizontal it is 2, vertical it is 3, distoangular it is 4. Then depth, level A, B, C, 1, 2, and 3. Then Remus relationship, class 1, class 2, class 3. Class 1 is adequate space to erupt. Then class 2 is partial space, and class 3 is no space. Okay. Then you can calculate difficulty index by making a total of it. Okay. If the total lies between 7 to 10, then it is very difficult case. Then if the total is 5 to 7, then it is moderately difficult. And if it is in 3 to 4, it means 1, 1, 1 from each level, then it is minimal difficulty. Okay. So mind this Peterson difficulty index. Okay. Then next is WARF assessment. WARF assessment. Just one. Can you remove this? In WARF assessment is it's a combination of the things like Winter's classification, horizontal, distoangular, mesoangular, vertical. They have a score: 2 for horizontal, 2 for distoangular, 1 for mesoangular, and vertical is 0. Okay. Then height of the mandible from 1 to 30 millimeter, 0. From this 31 to 34 mm, 1. From 35 to 39 mm, it is 2. Then angulation of third molar. Angulation of third molar, 1 to 50. This is a degree. Okay, 1 degree to 50 degree. It is 0. From 60 degree to 69 degree, it is 1. 70 to 79, 80 to 89, and 90 plus, it is 2, 3, and 4 respectively. Okay. Then root shape, very complex shape, 1. Favorable curvature, 2. Unfavorable curvature, 3. follicle normal 0, possibly enlarged 1, and very enlarged 2. Path of egress, if the space is available 0, distal cusps cover 1, mesial cusp cover 2, both covered 3. Okay. Now next is classification by Association, American Association of Oral Maxillofacial Surgeons. Okay. The classification system based on the dental procedure codes that are used by insurance carriers. These codes are based on clinical and radiographic interpretation of the tissue overlying the impacted mandibular or maxillary third molars. These are described as, these are the codes given, okay. D7220 for soft tissue impactions. Okay, there is no hard tissue coverage. 230 for partial bony infections, 240 for complete bony impactions, and 241 for complete bony impactions with unusual surgical complications. Okay. Now, very important thing, this is for the assessment how to take the tooth out or how to plan your surgery. Okay. So first part of surgery, it is Winter's war line. It is based on imaginary lines drawn on radiograph to determine the position and depth of the impacted tooth. Correct?
Yes.
So war lines are, W is for white line, A is for amber line, and R is for red line. So white line is a line passing through the occlusal surfaces of teeth. Then second line is passing through the cervical region, and the third line is here. Can you see this?
Yeah. So the point of elevation.
Yeah, point of elevation. It is a perpendicular drawn from the point of elevation. So there are incidents of impacted mandibular third molars. The mesoangular 43%, horizontal 3% because they are difficult. Then vertical 38%, and distoangular most difficult is 6%. Okay. Why distoangular is most difficult?
Because the path of exit is the opposite way.
Yeah, and the most likely thing is the roots are in unfavorable manner. Okay. When your roots are in unfavorable manner, it tends to be the tooth is not coming completely out. You have to section it. Correct? So what is the preoperative evaluation for this? Complete history should be taken. Okay, the patient should be checked for any underlying disease such as all these for the surgery, like blood pressure is the main thing. Okay, the patient is not having a high blood pressure or low blood pressure. The history of the patient, previous history of the patient regarding extraction, any extraction or regarding any dental procedure, local anesthesia history, then general examination, local examination, investigations, and then radiographic evaluation. Sometimes the patient is on any medically compromised condition, and like you have to take a physician consent also, that such and such, referring to you, such and such patient is this, okay, which needs extraction of the third molar, kindly provide consent, okay, for the procedure extraction under local anesthesia. The extraction may take from 25 minutes to 45 minutes. You have to write the guideline and then kindly opine. Then the physician will give the consent. So these are very medical legal aspects. They should be there in your hand. Okay. Not for all the cases, but yes, if the patient is medically compromised and giving a history, then do take consent from the physician. Correct?
Yes.
Then facial form. facial form, the patient, if the patient, what form of the patient is, in strong jaw bones or all, everything you can judge by local examination. Size of oral cavity, you saw a radiograph and okay, this is a very simple extraction, but when clinically you see the patient is having a very less mouth opening, like having very less mouth opening, like you can't approach it. Okay, so that becomes very difficult. Okay, so just by seeing a radiograph, don't jump onto any conclusion. Just you check for the mouth opening also. Correct. Then position of external oblique ridge, size of tongue. If the patient is having a macroglossia or a large tongue, then it will interfere in your surgical procedure. And your assistant, all the time your assistant will have to pull the tongue away. And it is very difficult sometimes. Okay, then oral hygiene. This is very important because if the patient is having lots of calculus and all, and you are extracting the any tooth, say not about third molar, any tooth you are extracting, then yes, there may be chances of super infection after that due to calculus and all the debris in the mouth, and the patient is still not maintaining the oral hygiene. Then endodontic problems, angulation of impacted tooth, caries, restoration on impacted tooth. Already some guys, they do restoration on impacted tooth sometimes. If it is a difficult extraction or something, and they are well versed with the restoration, they restore it, and later on the patient comes for extraction. Then you have to see the restoration. Or if sometimes they may have undergone root canal procedure also. In those cases, it is very difficult to extract the impacted third molar, because after root canal, the tooth tends to fuse with the bone also. Okay, why? Because it will act as a bone graft then, mostly, and the tooth will become a brittle one. A tooth will become a brittle one after root canal. Conditions of soft tissue and tooth, and position of opposing tooth. So these points should be taken into consideration. One by one, taken into consideration, everything. Okay. Then what are the assessment of risk factors? First is age, then location of inferior alveolar nerve, then interincisal opening. This is very important. Okay, interincisal opening, size and form of tooth, condition of the bone, size and form of the root. This is the size and form of the tooth, and this is size and form of the root. Relation with the ramus, adjacent tooth, and neurovascular bundle. Now, each of them has a different risk factor. Okay. Age, as the person is old, the bone becomes more tough and brittle. Okay. So there are chances of breaking the mandible also sometimes, if you are wedging it like this and using unjudicial forces. Then location of inferior alveolar nerve. In location of inferior alveolar nerve, yes, inferior alveolar nerve is a very important structure. Why? Because if the tooth lies in the inferior alveolar nerve or in a bundle on the canal, then what will happen? You may injure the inferior alveolar nerve while extracting the tooth. Interincisal opening, I have told you. Okay, if there is less interincisal opening, you may have difficulties in extracting tooth. Then size and form of the tooth. Too large tooth, they are very difficult to extract. Okay. Then condition of the bone, whether the bone is brittle, whether the bone is soft or infected. Then size and form of the root, whether the roots are bulbous, fused, separated, unfavorable. Then relation with the ramus, where there is adequate space to operate, or the ramus is just starting after the second molar and you don't have any space for surgical operation also. Okay, then adjacent tooth. Adjacent tooth, sometimes the second molar is having a root canal and a crown or a cap on it. Okay, so you may find some difficulties while placing elevators and all. The cap may pop out. Okay, then same location of inferior canal as a neurovascular bundle, same one. Most of the time we are concerned about mandibular third molar, because in maxillary third molar anything can happen. Okay, so relationship of the root to the canal. Okay, so it is related but not involving. If it is related but not involving the clause, mainly it is separated, adjacent or superimposed. It is related and changes related to the canal and changes in the root, like darkening of the root, If you see a radiograph and the canal is passing near it and there is a darkening in the root, okay, it means that it is involving the canal. By 2D photograph or radiograph, you can assess it is involving the canal. Correct? Then check for darkening and bifid root. Then check for narrowing of the root and deflected root. If the root is deflected, then it is above the bony canal. Okay. If the root is deflected, then it is above the bony canal. Now it is related and changes in the canal with interruption, loss of lines, converging canal or narrowing canal, and diverting canal. In this time, changes in the roots were there, and now the changes in the canal is there due to teeth or due to third molar. So this is the various things. As you can see, the involvement of the canal. Now in this, the bony coverage is deviated. In this, the tooth is into the canal. Okay. Or one root lies in the canal. So what about these cases? How you manage these cases?
Coronectomy.
Yes. Coronectomy should be done. And for these cases, sometimes coronectomy, sometimes we leave a apical third of the root inside. Okay. Now, management of wisdom tooth. A surgeon should know where to cut or where not to cut. Okay. That you will gain with the experience. Where to cut, where not to cut. If you are not cutting, that doesn't mean that you are not a surgeon. It means you have understood where not to intervene. Okay. So two phases are there, intervention phase or non-intervention phase. So treatment strategies based on assessing the all relevant is risk and benefits. What is the risk of non-intervention? If you are not intervening, what will happen? Perigonadis, it will happen again. Okay. Then dental caries of second molar and third molar. In these cases, you can see dental caries. Okay. Yes. Periodontal problems, root resorption of second molar, and it acts as a focus of infection also. As you can see here, mesenteric space infection extending to the temporal spaces also and involving the canine space. Can you appreciate in this?
Yeah.
Then there is anchorage loss, your orthodontic problems due to pressure effect on distal end of arch. See, this is still a questionable debate. Okay. But yes, there is an anchorage loss because it is pushing the roots like this. Correct? One theory says that pathologic lesions, biological behavior is unpredictable of any pathologic lesions. Okay. These are the dentigerous cyst with ameloblastoma. This is a dentigerous cyst. So if you try to extract or something like this, then there will be pain, paresthesia, anesthesia, rapid pain, and ear and neck region also. So you have to judge whether what are the main consequences. You have to explain to the patient that it is simply not a impacted teeth. It is related with some other biological lesions also. Okay, pathological lesions also. Pathological lesions predisposing to fracture of jaw. Okay, because the pathological regions, see in this case. Now, can you see the lower border of mandible here?
Yes, very thin.
Yeah, and this much of the mandible is involved. So there is very less bone here. So if you are applying some force and all, it may break from this place. Okay, it may break from this place. So these are the pathological lesions. One of the pathological lesions to for the fracture. Sometimes the patient comes with a fracture only, pathological fracture only. Like in this case, third molar is there already, but the patient is coming with a fracture. Okay. Now, whether if the tooth is in line of fracture or near the line of fracture, in both the cases, there is a dilemma whether to extract the third molar or not. See, if the tooth is in the line of fracture and the fracture is a favorable fracture, then after extraction, it may become unfavorable because the bone might slip. Can you see this?
Yes.
The bone might slip. So there is a risk of intervention in these cases also. Your favorable fractures may become unfavorable. So better in these cases are do the plating, let the fracture heal, and after 1 to 2 years, when there is a proper bone is there, then try to extract the third molar. Correct? Benefits of non-intervention, if you're not doing any procedure on this, first is avoid the risk of surgery, then preservation of residual ridge, for the purpose of auto transplant and for prosthetic considerations. Okay, your ridge will be preserved. Risk of intervention, minor complications and major complications. Minor is alveolitis. There is a swelling or inflammation of alveolar bone, 1 to 5%. Paresthesia. Okay. Trismus. Fracture. Hemorrhage. Okay. In major complication, dysthesia, bacteremia and infection. Now, what are benefits of intervention? What we are supposed to do regularly? Therapeutic control, uneventful healing, decrease morbidity in young patient, and operative and post-operative complications are less. Strategies are also based on socio-economic status of the patient. Okay. And if the patient is willing for extraction or not. Oral hygiene practice. Some dental surgeons wait for impacted tooth to become symptomatic. Some dental surgeons, they wait that, okay, if it is not giving you any problem, that leave it behind. Okay, when it will give problem, then we'll take out. Okay. Others have a preventive approach also. See, at my time, one of my third molars, it was giving symptoms. So I got it extracted. Then on prophylactic basis, 1, 2, 3, I got extraction of these. I got rid of all three, all four premolars then. Okay. So others have preventive approach, germectomy in the late childhood also, then lateral trephination and removal during the adolescence. The curative approach involved exposure of the crown of the tooth is in good position. Okay, but this is a nice one, a curative approach. But all these procedure, the parents even don't want their children to go for any surgery after. If the tooth is symptomatic, they only want then. Otherwise, they don't want any surgery. What is early prophylactic removal? The advantages are removal is easy. Root formation is not complete, so the removal is easy, and pericorneal space is wide. Then bone is more elastic in early age. There are less chances of any fracture. Then healing is uneventful. Morbidity of periodontal tissue is reduced, and operative and post-operative complications are less. Disadvantages: accurate clinical judgment and motivation for extraction in early ages is challenging to the clinician. That was I was studying. It is a challenge to motivate the patient in early age. Then disadvantage of advancing age or late therapeutical removal. Technically, the extraction become difficult and tenacious. Unfavorable and bizarre root morphology can be there later on. Bone become brittle and sclerosed. Okay. Healing is not satisfactory. Then more amount of bone removal is required in late age. More discomfort to the patient. Advantage is therapeutic removal is done to treat inflammatory component. The patient motivation is not a problem because patient already comes with pain. Yeah. So preoperative evaluation, already we have discussed history, general examination, local examination, investigations, and radiographic evaluations. In radiographic evaluation, these are the various points which have to be assessed. We have to take proper IOPs or OPGs. The check for the neurovascular bundle in this, deflection of the canal, notching, darkening of roots, loss of correct cortication. Now, various type of impacted radiographs are there. So in your dissertation, you have to collect either IOPs, okay, or OPGs. Okay, various OPGs, and to prepare for the war line and find out the difficulty index. Correct? OPG gives a clearer picture.
Yes.
Then counseling of the patient. If you counsel the patient well, then there is a increased patient compliance, a reduction of anxiety and fear is there. Don't allow patient to watch YouTube before coming for impaction because it may ruin the thing. Okay. Then because in YouTube the videos, old videos, they come first. Okay.
Yes.
If the patient is opening the video of 1995, 96 or 2000, 2001, that video will come. Okay, no video of recent technology or recently non-invasive procedure will come. It will come with a lot of surgical exposure, like you do in implants. If you search for implants, they will open up all the space and all. Okay, so patient get an anxiety and fear. Then selection of anesthesia, routinely used drugs, need for other drugs and alternatives. Anxiety reduction protocols, proper counseling, do give morning appointments, sedatives and other drugs.
Yeah.
Armamentarium, your armamentarium should contain everything. Okay, when you are extracting the third molar, right from irrigation to the micromotor. You use this type of T-bars, T-crossbars?
No.
No? Okay. See, these are very helpful, but sometimes excessive force is there. They may cause a fracture also. Now, various incision, the first one is ward 1 incision and second is ward 2 incision. What is ward 1 incision? Ward 1 incision, it starts from distal of second molar. It is starting from the distal of second molar. Ward 2 incision, it starts from distal or mesial of second molar or distal of first molar. Okay, these are the extensions. These are the extensions. If your incision is deep and sharp, okay, your half of the surgery is very easy. Otherwise, tissue tags or granulation will come in between your surgical procedure. Okay, so this is a modified ward incision. Modified was, as you can see here. Okay, so modified ward incision means envelope. It may extend up to the mesial of first molar also. Okay, see, whether you take a long incision or a short incision, they both will take equal time for healing. Okay, so don't be any miser in this taking the incision. And after this, flap reflection is there. After flap reflection, you may be able to visualize the third molar. Can you see this?
Yes.
Can you see?
Yes.
Bone cutting can be done by straight handpiece or a contraangular handpiece. Sometimes odontectomy should be done with contraangular also. Okay. Burr and chisel mallet. Chisel mallets we are not using nowadays. Okay. Very less we are using. In maybe in some upper we use. Bone guttering is there. Okay. Remove bone from the buccal and distal aspects. Buccal and distal aspects. Mesobuccal, distobuccal, distal aspects. Okay. After you do the adequate bone removal, you get a purchase point. You get a purchase point. Then, if the tooth is deep enough, you don't like to have, you don't do bone guttering till here. Okay, you can just split the tooth, make it into two single rooted teeth, make it into two single rooted teeth, and then remove it one by one. Remove the distal part first. Remove the distal part first, and then mesial part is easily removed. Correct? In this case, single rooted tooth is there. You have to do an odontotomy like this so that this obstruction is removed because this area is less than this. Then you have to push it like this and you can remove it. Correct? You can remove it with the path of extraction. Odontectomy of distoangular tooth. In distoangular tooth, the odontectomy should be remove the coronal part first. Remove the coronal part first. Then split the root or take the root out in one chunk. Correct? So these are the very difficult ones. This triangular one, you will take ample of time in doing the coronectomy of the first, the crown. Now odontectomy of horizontal tooth. In odontectomy of horizontal tooth, this is a horizontal tooth. So first take the crown out. Okay. Then take the upper root first, and then lower root and the slip of the crown, they can be easily taken. Correct?
Yeah.
Then what is arc of rotation? Arc of rotation is the rotation in which the teeth is extracted. Okay. So for all teeth, the arc of rotation is mesial to distal. Mesial to distal. So you have to check it for each and every tooth. Okay. Now in this, the tooth is obstructing in the canal. Okay, bony canal is there. If you apply excessive force, what will happen? The crown will. So the arc of extraction in this, what should be the arc of extraction in this? If you will apply force, it will give injury to the nerve. The patient will not comply with the extraction. Okay, so you have to split this tooth like this. Take the crown out first. Then you can pull the root.
Pull the root up.
Okay, pull the root up. Why? Because then there will be no pressure or on the canal. This, then elevation, and then removal. Then this should be the flap is sutured back. Flap is sutured back. Now, some part of odontotomy can perform with a contraangular handpiece also. Contraangular handpiece also, because for straight handpiece, it is difficult to do distal of the second molar. Okay, it takes time. It definitely takes time, but the procedure is uneventful and good. Okay. Then flap is sutured back. Post-operative care, antibiotics, anti-inflammatories, physiotherapy of hot and cold. First 24 hours you give cold, then you can give hot and cold mixed. Okay. Sometimes some surgeons, they use Grisling Waxel dressings also to reduce the inflammation, and sometimes steroids are given. This is still a debatable topic. Okay, whether to give steroids or not. Now, what are the various complications in various steps? Incision and flap design, if the complications are pain, trismus, bleeding, edema, erulitis, dehiscence, and infections. Okay. So, various complications are there. Okay, in the this procedure. So managing complications, it's just like we have discussed in this implant also. Post-operative complications are like pain, trismus, bleeding, edema, erulitis, dehiscence, and sometimes infection in very if the patient is having a very poor oral hygiene. Okay, so sometimes you have to change your antibiotics after 3 to 4 days. Okay, in some cases, you have to change your antibiotics also if the infection is not resolving. Correct? So, if you have time, we can go for another small lecture of medically compromised conditions also, medical emergencies also. You have time?
No, I have a patient now.
Okay. Then we'll continue on Monday, on Wednesday. Okay.
Yes.
Wednesday, do you have time for 2 lectures? Because I think next Friday.
Yeah, sure. Yes.
Next Friday, I have a workshop in another city, so we'll take 2 lectures on Wednesday. Okay.
Yeah.
Bye. Take care.
Okay. Bye. Thank you.
Bye.